which is the cones of considering 7 is the transfusion threshold for all patients in the ICU, basically. So I still thought 7 has been the magical number sort of for transfusion all along. We all use it. We all see it every day. We all transfuse patients if they're in the sense 7. But is that truly the magic number? What's so special about using 7 as a threshold? Why not use 6 or why not use 8 or 9? Trials have tried to actually answer this question, and TRICC Trial was one of them, as Tony has gone through it. It didn't even have 7 as a transfusion. If you look at the concentration of hemoglobin right after for the restrictive group, it wasn't even 7. So right from the start, 7 wasn't the magical number in the TRICC trial. Do we have other studies that have other data in another direction? Yes, we do. And in fact, they're a little bit different from the TRICC trial. We have a few other trials that looked at the transfusion goals and transfusion threshold, and they were quite different from the 7 threshold. So maybe the scope of this lecture is not to say, well, should we transfuse less or should we transfuse more? Maybe we should look at it as, do we really need to consider 7 as the magical number for all patients, or do we have another number to look at, or is there even a number to look at in order to determine which patient needs transfusion, or can we just look at the patient data, look at the patient status, are they in shock, are they not in shock, and transfuse based on that? That's what I'm trying to answer during my part of the presentation. So let's start with a simpler question. Why should we avoid transfusions, or should we avoid transfusions? And we do have some data. It's mostly observational data. I found a nice systematic review that's a little bit old in 2008, but it did have a good number of studies, and they all said that there is an association, at least, between more transfusions and increase in mortality, increase in infections, organ dysfunction, acute respiratory distress syndrome, maybe even other stuff like sensitizing people to organ donation in the future, so they need a transplant. So there have been some, at least, associations between more transfusion and worse outcome in many ways. I will go back to that in the second part of my presentation, but this is part of the answer to the question of why should we avoid transfusions. Now, let's look at another trial that addressed this question. It's called the Transfusion Requirements After Cardiac Surgery, published in 2010 in JAMA. Now, this study was nicely designed. It's a randomized controlled trial. It was a non-inferiority trial, meaning they looked to prove that a restrictive transfusion strategy was not non-inferior to a more liberal transfusion strategy, and it was analyzed by intention to treat. And this is particularly important to those kind of studies because you will have some sort of crossover rate. You'll always have that patient who is bleeding actively. You'll always have that patient who has symptomatic anemia, and you will end up transfusing them no matter what. So it's always helpful either to do an intention to treat analysis or to assign them to start with in the restrictive strategy. In this particular study, they actually chose to do intention to treat analysis. 500 patients, give or take, they all underwent cardiac bypass surgery, and they were randomly assigned to either a liberal strategy with a hematocrit of 30, roughly 9 to 10 of hemoglobin, or to a restrictive strategy with a 24% hematocrit, roughly equivalent to 7 or 8. Outcome, they looked at the endpoint mortality of 30-day all-cause mortality and severe morbidity. The patient developed cardiogenic shock, ARDS, or AKI requiring dialysis, or any form of renal replacement therapy. Now, interestingly, the hemoglobin concentrations were 10 in the liberal group, or 10.5, and they were 9.1 in the liberal group. So again, no mention of the number 7. As you might expect, about almost twice as much patients from the liberal strategy group got actually transfusion as opposed to half of that, almost 47% as opposed to 78% in the more restricted group. This is the primary outcome of the study. You can look at the time from the beginning of the study as opposed to the probability of mortality. And although there was a small trend towards more mortality in the patients with the restrictive strategy, but this wasn't really statistically significant. So basically no difference, you could say. Now, this is different. So here this is the actual primary outcome. This is the intention to treat analysis that the study was meant to be. This is not the primary outcome, but they did look at the mortality based on how many units you got, actually, regardless of which group you are assigned to in the first place. for example, as we said, it was an intention to treat study, so in the restrictive group, you might have a patient who is actively bleeding, you might have a patient who have symptomatic anemia, so they might have gotten 4 or 5 or 6 units of blood. Those patients in particular, regardless of they belong to the restrictive or to the liberal group, they actually have higher chance of mortality, particularly if you've got more than 5 or 6 units. But once again, this was not the primary outcome of the study, and this was more of a site analysis that they just got out of the numbers they had. Let's look at the next study, which is the FOCUS trial, liberal or restrictive transfusion in high-risk patients after hip surgery. So surgical patients, more or less, was published in 2011, very next year. They had around 2,000 patients, all 50 years old. They all had cardiac history, either risk factors or significant risk factors or a history of cardiac events or cardiovascular disease. And they all had hemoglobin of less than 10 to start with after the hip replacement surgery. They were randomly assigned to 2 groups, one with a threshold of 10 for transfusion, the other was restrictive, and the number they used was 8. The primary outcome was death, or interesting choice of outcome actually. They looked at inability to walk across the room without human assistance in 60 days. It's not an outcome we usually see in all these studies because we often look at mortality or morbidity or cost or all these things, but it's nice to look at an outcome that actually deals with functionality for a change. So this is the hemoglobin levels and transfusions. Before surgery, they were all 11.3. During the screening, they were around 9. Right before transfusion, the restrictive group was around 8, 7.9. The liberal strategy was around 9.2. So basically 8 to 9 is what they were looking for, and was statistically significant. Now, as you might expect, the restrictive group, about half of them never got any transfusions, and the liberal group had significantly more number of blood units transfused. This was not the case for the other blood products, platelets or any of those. And that's what I was talking about here, is that the patients who actually get transfusion because of symptoms are significantly more in the restrictive group. So you might choose to start with a more restrictive strategy towards transfusion, but you will eventually get stuck with patients who require more transfusion just because they're symptomatic or they have a significant bleeding. And they were statistically significantly more in patients in the restrictive strategy. Now, the outcomes, I could go through all of that, but I really don't need to because they're all non-significant. They looked at many outcomes, MI, death, cardiac events of any kind, strokes, new infection, VTE, or transferred to the ICU, and they're all non-significantly different from each other. Next, I will talk about the FOCUS trial, which was published just last year. This is actually just following up 3 years after the initial study. So they looked at the same patient pool, and they just followed them 3 years later, and they looked whether there is a difference in mortality or not. Now, the average follow-up period was 3.1 years. Some patients were followed actually for much longer than that. They just linked the primary patient pool to the death registry in the United States and Canada, and they were again done by intention to treat. And as you can see, there was not much of a difference. Even for the patients who were followed for up to 6 years, there was no difference in mortality. And the last trial I'm going to talk about is this, was published again last year, liberal or restrictive transfusion after cardiac surgery. So again, cardiac patients. Patients were all adults. It was done in the United Kingdom. That's actually the reason I didn't put the cost in here, because they actually one of the few studies that actually looked at the cost, but unfortunately it was in the United Kingdom, so the cost could be much different from the United States. They all had a post-op hemoglobin level of less than 9, and they were randomly assigned to restrictive transfusion threshold 7.5. This is probably the closest we have to the magical number of 7, or to a liberal transfusion threshold 9. Primary outcomes were many. None of them was death, actually. The mortality was not one of the primary outcomes of the study. But they did look at serious infections, ischemic events, even gut infarction, MIs, or acute kidney injuries within 3 months of randomization. Again, they looked at the cost, but that's probably not relevant to what we're talking about here. About 1,000 patients in each group. And if you look here, same as you'd expect for any other study, the number of patients who actually got transfusion was much more in the patients who are in the liberal group, and about half of the patients in the restrictive group did not get any transfusions. This is again looking at the outcomes here, and as I told you, mortality was not one of the primary outcomes for the study, but there was a, you could call it a significant difference in mortality, but it wasn't that much different either. So really there was nothing much here, just showing the primary data, risk factors, and whether they're present or not in both groups. So after the review of this data, should we really consider the transfusion limit of 7 as good enough for all patients, or do we have data to suggest otherwise? So let's look at the very first question. Why do we avoid transfusions in the first place? Now, we did say that we have some evidence that transfusion is associated with worse outcome. It's associated maybe with more mortality, maybe with more infections, maybe with more sensitizations. But there's a lot of these studies, at least the ones that I looked at, were actually observational studies. And observational studies, by definition, would have some confounding bias. So are they all biased? Probably not. But at least we can't really tell for sure they're not biased, at least not from the data we have. So what do we do here? We go for randomization, which we looked at next. So the TRICC trial was the big one in this, and that's probably the one that has the most effect on whether we choose a restrictive or a liberal one. And as we saw in the first part of the presentation, there was a trend towards a lower 28-day mortality in the restrictive versus compared to the liberal. But the big thing here is that the hemoglobin concentration was actually 8.5 as opposed to 10.7. So is 7 really better than 10? Not according to TRICC trial, because the patients who actually had a better mortality were around 8.5. So there was a great discrepancy between the primary design of the study and what it actually came to. Also, the restrictive group had a hemoglobin of 8.5, significantly different from the 10.7, and we do have data that's well established that anemia is associated with higher mortality, is associated with cardiac events, and associated with longer lengths of stay in the hospital. So we have observational data that suggests both ways, that suggests that lower hemoglobin will result in more mortality and more bad outcome. We also have observational data that states the other way around, is that more transfusions causes that. And randomization didn't really point us one way or the other, especially if you consider 7 as the transfusion cutoff point. Now, according to this, if you have 8.5 as the cutoff point, maybe you can consider it, but not according to this trial. Let's look at the next trial, which, yes, showed no difference between all-cause mortality and severe morbidity between restrictive and liberal groups. But, once again, the average hemoglobin in the restrictive group was 9.1. It's really different from the 7 that we usually aim for. And it was different to 10.5, so all what we talked about the worst outcomes that are known to be associated with anemia is still there. How about the FOCUS trial? Same thing applies for it. No difference in the primary outcome, but we do have a hemoglobin that is about 8, different from the 7 that we use usually. And it has also the added adverse events, if you will, that more patients were actually transfused out of the protocol just because they were symptomatic or because they were actively hemorrhaging. Last thing, the last trial we have is no difference in primary outcome, but once again the restrictive transfusion threshold was 7.5, it wasn't 7. So do we really have evidence to suggest that a more restrictive transfusion strategy could be beneficial to patients? Yes. Do we really have an overwhelming evidence that 7 is the magical number and we should use it for all patients and we should always transfuse it less than 7 and hold if it's more than 7? I would say probably not. As Dr. Rivers pointed out, maybe if we use more sophisticated methods that would actually determine what is the total body content of hemoglobin or RPCs, and based on that we might go for it, and yes, of course. But up until then, maybe we should take this transfusion of less than 7 with a grain of salt, at least consider other things with it, like the clinical status of the patient, which we all do, by the way. I mean, we all transfuse more patients if they're hemorrhaging, if they're cardiac patients, if they're having any sort of symptoms for the anemia, we all do it, or prior to procedures. But maybe this also should extend to other patients in the intensive care unit. It's just some of the references I've used, and that would be it. Thank you. Any questions?
I'm sorry, back to my question.
Yes.
Why 8 and 21?
Why do we use 8, and why 8 was?
Yeah, why
Okay, hello everyone.
Hi.
So it seems like we're going to start. Doesn't seem like we're going to have a bigger group than this. The topic today is transfusions in the ICU, kind of having a pros and cons debate between the restrictive and liberal strategy. For the purpose of this discussion, we're taking restrictive as using hemoglobin less than 7 as a target. Okay, so just to give this a little bit of a background on why this topic is important. Anemia in the ICU is fairly common, like I'm sure we all know. Pretty much everybody or like a large proportion of patients who go into the ICU end up becoming anemic, and quite a few of them get transfusions as well. It has been estimated that as much as 2/3 at the point of which they go into the ICU, most people don't walk in, at the point of which they go into the ICU are already anemic. And then by day 3, almost everybody is. And the reasons for these findings is kind of like multifactorial. One of the issues is that the etiology, that the reason why the person went in the ICU in the first place kind of contributes, because a lot of people have decreased synthesis of blood products while in a state of critical illness. There's quite a bit of blood sampling as well, and if anyone here has ever been in the ICU, the first thing we do is get some blood cultures. Despite the fever the next day, we get more blood cultures. And also there's a lot of wastage of blood. Another factor that might not be well recognized is the presence of gastrointestinal losses. Even when we do not have overt bleeding, there is quite a little bit of blood being lost. It's quite a significant factor in outcomes in the ICU. There's relation to mortality, failure to wean off mechanical ventilation, length of stay in the ICU, and functional status post ICU discharge. Something we may not necessarily be aware of, because as critical care providers, what we think is, yay, he got transferred out of the ICU. What happens to him thereafter, we never find out. Now, the goal of blood transfusion for anybody in the ICU or not is to restore hemodynamic stability and improve oxygen delivery, even though a lot of studies have come out and shown that it's not quite as clear-cut as we think. There's no linear relationship to the amount of hemoglobin and the amount of oxygen delivery. So, pretty much the landmark trial was the TRICC trial. For the purpose of this discussion, we're going to go through a few trials, none of them in too much detail, just the highlights. This was done in 1999, getting close to 20 years now. So what we had here was 838 patients who had hemoglobin of less than 9. These were the patients who were selected into this trial. The study was done in 25 ICUs across Canada, and it was pretty much split in half, and half of these patients were transfused if the hemoglobin fell to less than 7 and maintained between 7 to 9, and the others were transfused when the hemoglobin fell below 10. Of the measured outcomes that were selected, there was no real significant differences in outcomes. And then in terms of funding, it was kind of like unbiased funding. I know we always ask where did the money come from and that kind of stuff. It was kind of unbiased funding, so there was no agenda here to be suspicious about. One of the surprising findings was that the restrictive group had significantly lower mortality, which is not what you would expect. You would think that since these patients were already hemodynamically stressed, giving them a little bit of support would improve their outcomes, but that's not quite what happened. There was no difference in duration of mechanical ventilation, so the lower hemoglobin thresholds did not make difficulty, did not create any difficulty weaning off mechanical ventilation. Now, for patients who were less ill or younger, the 30-day mortality was lower for patients in the restrictive transfusion group. So even the findings were even more pronounced in those who were younger and less ill. And I'll suggest a couple of reasons why this might have been the case. This is kind of like the study flow chart. Pretty much the same thing I described in the previous slide. Here we have the outcomes. For all the things that were measured, there was pretty much no difference. So there was no difference in 30-day mortality, 60-day mortality, or hospital death. We have also no difference in terms of length of stay, no difference in length of stay in the ICU or in the hospital. Now, the one important factor is that maintaining the hemoglobin in the 7 to 9 gram per DL range decreased the amount of red cell units by 54%. So even though there was no difference in outcomes, you spent less blood. These are the characteristics of the patients who died. No significant changes or differences between the two groups of patients. And this study, while it was noted to be a landmark trial, had quite a few limitations. One of the first ones is that a very low number of patients who were screened eventually ended up in the trial. Another one was that they had a very low enrollment of patients with cardiac disease, and one of the thoughts regarding this is that either the patient or the caring physician kind of objected to anything that might have compromised their cardiac status even further. Now, looking at the mean hemoglobin of both groups, for the restrictive group, they were going to transfuse for 7. But here we have means of 8.5 and 10.7, which is way above what you would expect if you only gave for less than 7 and less than 10, which is kind of weird. I did not quite find an explanation for that. And at the time this study was done, they did not use leukoreduced blood. So they had white cells in the blood that they gave, and one of the factors that might have contributed to the adverse effects might have been the immunomodulatory effects of having white cells in blood. That's not the case anymore. Nobody does that anymore. So for those who got more transfusions, one of the thoughts is that if you got more white blood cells, then you had a higher immune-mediated response, and then you had poorer outcome. I said at the time the study was done, the blood transfusion practice did not use leukoreduced blood. Now you take the white cells out. So now if you're giving blood, you're giving straight red blood cells. Did that answer your question? Okay. All right. So another study which we talk about was the TRISS trial. It was pretty much a rider of the TRICC trial. Thought was that for septic patients, the findings will be different. And it was a multi-centered randomized trial, 32 ICUs in Denmark, Sweden, Norway, and Finland, very homogeneous Scandinavian population. Patients who were being treated for sepsis were randomized to a restrictive group to be transfused when the hemoglobin fell to 7 or less, and a liberal group of 9 or less. Primary outcome was death at 90 days. Once again, here we have the flow tree. Nothing really exciting there. And the characteristics of the patients, no major differences between the two groups. One of the things I noticed, which I'm not quite sure what the clinical significance is that the number of patients who had surgery was kind of high for both groups. In terms of outcomes, no difference, again, no difference in the patients who died at 90 days. Use of life support anywhere down the during the course of their hospitalization. No difference in ischemic events in the ICU. Severe adverse reactions, no difference. Inotropic therapy, no difference. No difference in any of the measured outcomes. So we can pretty much say that you could easily get away with using the restrictive protocol in septic patients without risk of increased adverse events. Now, one of the important findings is that for patients who were in the restrictive arm, they got 50% fewer units than those in the liberal arm, and then 36% of patients in the restrictive arm did not get any blood transfusions at all, compared to 1% in the liberal arm. This is another study. It's really not directly linked to the ICU. It's pretty much a Cochrane database systemic review of transfusion in general, but this is where we get our transfusion policies from. They had 19 trials. 75% of the statistical information was contributed by 2 trials. Now, these 19 trials were spread across 55 years. So I'm sure medicine had changed so dramatically in a 55-year period. None of the outcomes were affected by restrictive strategy. And in hospital mortality and infections were 23% and 19% higher in patients receiving liberal transfusion. So they suffered, people who got more blood suffered more adverse reactions as well. And that was the final recommendation. Patients who do not have acute coronary disease, blood transfusion can be reasonably withheld in the presence of hemoglobin levels as low as 7 to 8, as long as there is no overt bleeding. Now, there were a few other studies which I'm not going to be able to present, but none of them showed any worsened outcomes if they had a restrictive strategy versus a liberal strategy. For the only one which showed a difference, which is the use of blood transfusion in GI bleeds, those who had a restrictive strategy actually did better, which is the study before the last. They actually did better if they got less blood. Now, the argument for a restrictive strategy, from all the studies I've presented, we do not believe that there is any increased benefit from giving more blood. And from same source, we also believe that the liberal strategy causes you to have more risk for adverse reactions and more risk for mortality. We also believe that the restrictive strategy will prevent you from suffering complications, and there are quite a few. Even though with the increasing safety of blood transfusion practices, the adverse reactions are becoming fewer and fewer by the day, but they are still present. It's still something that exists. So we must not treat blood lightly. And the last part is cost. In terms of cost of blood transfusion, the average cost of procuring a unit of blood is estimated to be somewhere around $260 for a unit. Most patients get a few units, and that's without taking into account the cost of labor. So if you take into account just the cost of procuring the blood, about $260. By the time you multiply it across all the units and all the hospitals all across the country, it ends up being quite a significant amount of money. At the end of the day, it's kind of like a cost, benefits, and risk calculation. We know there's increased risk of giving blood. We know that there's no actual benefit of giving blood, and then we know that there's increased cost. So if you were going to go one way or the other, you have two things that you do not desire and one that you do. So I would think that it's pretty straightforward, that we restrict blood, and I will leave it at that.